Hi, everybody. It's Patty Rydell. Welcome to 240. Congratulate yourselves on making it through the final and getting a little weekend to recuperate. You guys are the first class to migrate right from third to fourth ever that I know of in the history of my teaching here. So give yourselves a pat on the back. Take a deep breath, get your calendars out, look over Canvas, make notes of all the key dates of clinical, course, Kaplan, and get your schedule ready. Let's get going. Well, this PowerPoint lecture, will be mainly about ICU critical care topics and math and calculations. But the topics for the first week in 240 are usually IV therapy, critical care, and delegation. But what you'll do for delegation is the packet I loaded up, go over the principles and work the questions, and we'll go over the answers in breakout rooms in Zoom. For IV therapy, please review your complications. I know that most of you guys have practiced PICC line care, have been around IVs, and know about CLABSI. And now you're going to be inserting an IV and pushing IV medications. So key things to be looking out for: nerve damage when you do an IV insertion, or speed shock when you're rapidly infusing a drug, or circulatory overload. Most of you know about that. But there's a local complication and systemic complication page. And there are about 13 complications between the two. Please review those, as well as your instructor should have gone over them on skills day for this weekend. They should be going over them. Okay. Well, great news. If you want to be an ICU nurse, the outlook is awesome. There's a healthy outlook for California ICU nursing jobs. There will be a large transformation of the workforce in about 5 to 10 years, when the bulk of nurses in the state of California are going to be retired. So there'll be lots of openings, and if you're interested in critical care, this is just a very quick little mini course lecture on some topics. But if you get hired into critical care fresh out of school, you should be going to a critical care course of 8 to 10 weeks, 1 day a week, and then be assigned to a variety of patients to care for all these devices and things you're going to learn about today. There are many types of ICUs. There's medical ICUs, trauma ICUs, cardiothoracic ICUs, pediatric, and burn. It's a specialty in itself, but for the most part, most of the hospitals we're rotating at have basically 1 or 2 ICUs, and all the patients are mixed up and they all go into that ICU. And you can see these pictures here. There's a lot of technology that surrounds patients in the ICU, and we're going to get talking about that shortly. The critical care unit is all about teamwork and collaboration. As you can see from some of these photos here, you can see the respiratory therapist bagging the patient in the upper right-hand corner. There's a lot of collaboration between the ICU nurse and the intubated, ventilated patient. Most respiratory therapists have gone to school also for 2 years. I am a former respiratory therapist who then became a registered nurse and worked in the ICU. So we did ventilator care, ABGs, and breathing treatments, and worked closely with the nurses. You can see in the lower left-hand corner picture, that is like a teaching hospital making rounds to each ICU bed. My favorite place I worked was St. Mary's Medical Center, was a teaching hospital where there was a residency as well as a fellowship in cardiology. So there were a lot of pacemakers and Swan-Ganz pulmonary arteries being put in, and it was a fun place to work. Also UCLA I worked, and we did daily rounds with residents, social worker, dietitian, and respiratory therapist. Why would somebody be admitted to the ICU? Well, you can see here major trauma, extensive broken bones, unstable chest, perhaps a post-op heart, lung, or transplants. These patients usually come out intubated. They have chest tubes and central lines and pulmonary artery catheters and require astute monitoring. Critical labs, can you think of any? Definitely extremely low potassiums, like 1.8, or very critical labs in the sense of the kidney labs, which would be your BUN and creatinine if someone's in acute renal failure and requires acute dialysis at the bedside, is unstable, they might go to the ICU. Unstable vital signs. Well, if you're on the med-surg floor and your patient has hypotension unresponsive to maybe a fluid challenge or unstable SAT, they need to be intubated, or a very high temperature coming out of surgery, a hyperthermia, they perhaps could go to the ICU for that. Another area is advanced technology. You cannot take care of a ventilator or a post-cath usually on a med-surg floor, but there are some new units with cath post VCDs, that's supposed to say VCDs. Intra-aortic balloon pumps, always in the ICU. Those are used for cardiogenic shock. Every patient who needs mechanical ventilation must have an ET tube, endotracheal tube. So for the most part, when an endotracheal tube is put in, it's put in by a physician, usually an ER doctor. It could be a physician assistant. On rare occasions, a nurse practitioner, rare. Usually on the West Coast, it's a physician. The patient is prepped, usually sedated, and the doctor, respiratory therapist, and RN assist in the procedure. Well, you can see all the key things you should be concerned about. Literally, after intubation, immediately, placement should be verified. The most accurate way is by checking the end-tidal CO2 monitor, which is a small plastic device. You could Google that. It changes color when it's attached to the ET tube and tells us it's in the lungs. When it's in the lungs, the CO2 changes the color of the device. The nurse and the RT want to assess for breath sounds, especially bilaterally. If the ET tube has migrated down the main stem bronchus, it's usually the right main stem. You would only get breath sounds on the right side. You need to reposition the tube. The RT is mostly in charge of the ventilator. The RN assesses and monitors all the things you see on the right. It's very important to have an ambu bag. That's supposed to be an ambu bag. For rescue at the bedside in case there's any issues with the respirator. Well, a lot of you have the 8th edition or 9th edition, and there's some best practices for patient safety and quality care of the patient receiving mechanical ventilation. Please review those, the first 10. Review those. When should we assess the patient's respiratory status? Well, if they're in the ICU, it's probably it's continuously. It's hourly. We're taking vital signs. We're assessing the SAT. We're looking at the chest. We're looking at the blood pressure. We're evaluating ABGs as needed. We're keeping the head of bed up at 30 degrees to prevent VAP. The alarms are set. There's suctioning. The patient needs to have oral care to prevent the secretions from pooling down the back of the throat. After the patient's extubated, oral care is needed. Patients sometimes have retained secretions from the ET tube and the cuff. Here you can see some equipment right here. We're not going into the ventilator. The ventilator is going to be during the lecture for ARDS, respiratory failure and advanced ABGs, later on in the course. This is all about introduction of somebody who's been intubated. So most of the things you're going to be looking at is critical rescue, patient-centered care in your IGGI books, and managing care. So, hemodynamics is a big part of critical care. And how is it a big part? Well, Most patients have specific central lines that have been put into their subclavian or jugular vein and floated into the superior vena cava and into the right heart and even into the pulmonary artery. That's called a pulmonary artery catheter. All these specific catheters are there to measure and monitor the factors that influence the force and blood of flow. So this helps the nurse diagnose, monitor, and manage the critically ill patient, as you could see. We're going to be talking about things like cardiac output, stroke volume, preload and afterload. You had a lecture in 232 on the heart and the MI and post-cath, and now we're just going to take it a little further. Mr. Robbins will go into arrhythmias and cardiac surgery later in the course. So once again, what's the purpose of these lines? Well, these special lines, pulmonary artery catheters, otherwise known as the Swan-Ganz, or a triple lumen, or something called a cordis. These are all put into the large veins of the neck and subclavian. They are inserted by MDs, and the biggest thing if you're a nurse in the ICU to watch for is an air embolus or an arrhythmia during insertion. Be on the lookout for those complications. Some of the lumens in these lines can be 3 or 4. Flushing protocols. If you go through an ICU training program at a hospital, you'll learn how to work with the transducers, level them, the flush bags, or the manual flush if they don't have a flush bag. So always follow your hospital protocol. Most lines, as you can see, stay in for a max of 5 days. Why? What's the biggest complication with leaving a line in a patient longer than 5 days? Correct, infection. These can lead to sepsis. Just like CLABSI, we have central line acquired bloodstream infections of the big lines in the neck and chest that are put in post open heart surgery or trauma. And so they tend to only leave them in for 3 to 5 days. Usually they're there to monitor cardiac output, to monitor waveforms like pulmonary artery pressure, and to initiate drips like dopamine, dobutamine, and levofed. Well, I wanted to include the hemodynamic values, and I found this picture on the internet, but I want you to know that Iggy says in adults, the cardiac output ranges from 4 to 7 liters per minute. So you can see here 4 to 8 liters. And you know, honestly, at the hospitals where I worked, we went by the 4 to 8 liter method. And so sometimes you'll see a little variability, but what is cardiac output? Well, you know, it's very important to know how to calculate your cardiac output. So what you can do is take your pulse right now. I'm going to take mine. And let's just go with the average stroke volume. And so, you know, if you look in your book, it doesn't give you an average stroke volume, which is the amount of blood ejected by the left ventricle. But we can just go with, say, 70 milliliters. And if you take your pulse, and I got an 80, and I times it times 70 milliliters, that's 5.6, if I do the math. So is my cardiac output within normal range? Yes, it is. Now, cardiac output is a measure of heart rate and stroke volume, but look at stroke volume. It has many influences. The preload, the afterload, and the contractility all affect cardiac output. So make sure you review those topics in your book. I know that for the 8th edition, it's right around pages 630, and the 9th edition, 644. But you learned just about a week or two ago in 232 for the heart lecture that preload is the degree of stretch at the end of diastole. So it's the filling pressures. Afterload is the amount of pressure or resistance that the heart has to pump against. The ventricles have to overcome this to eject the blood. So it's all about the resistance, afterload. Contractility is all about the ability of the heart to contract. The contractility, the force of contraction, influences the stroke volume as well. So take a look at those key hemodynamic values. So get ready to practice how to calculate your own cardiac output. Make sure to go on Canvas and go through the 240 lecture mini outbreak in Zoom. We're going to be doing that on Thursday. Also, how to calculate a MAP. You know, most patients in the ICU are on monitors, A-lines, Swan-Ganz catheters, and these monitors calculate the cardiac output, the pulmonary artery pressures, and the MAPs right there on the screen. But it's all good to learn how to calculate your own MAP because it could show up on a test. So, for instance, on your little 240 lecture mini breakout, we're going to go through questions 1 through 4. We're going to talk about how to calculate a MAP. We're going to talk about how to run a K-writer. We're going to talk about things like what makes your cardiac output go up and what makes it go down, and what kind of drips do you usually see in the ICU. Most of the drips in the ICU are given to patients who suffer a lack of cardiac output, who have too much cardiac output, like an arrhythmia gone wrong, rapid atrial fib, or SVT, or hyperthermia. Anything that causes the cardiac output to go up or down might require a drip. Some of the drips that we'll be talking about, like dopamine, come in 3 dosages: renal dosing, intermediate dosing, and alpha dosing. We're not going to get into the dosing. This is just a quick 2-hour course max, but we'll talk about what is the action of dopamine, how does it help the patient, and what does the nurse monitor for. Once again, the nurses monitor these lines and they monitor the actual hemodynamic pressures. They do this through the transducer, which is hooked up to the monitor. You'll see in the next slide what a monitor looks like. You can see, based on this schematic, that the pulmonary artery catheter is floated all the way to the pulmonary artery. And usually the ports are either flushed with a bag of solution hanging, a pressure bag to keep them open, or they're usually hooked up to a drip of some sort, and that drip is hooked to a pump. And so you can see this specific catheter has 1, 2, 3, 4 ports, and then there's a balloon. There's a little syringe sticking out of it. This is not the best. It's not a color photo, but the balloon syringe inflates a small balloon in the pulmonary artery, which then wedges. It's called a pulmonary artery wedge pressure in the pulmonary artery, and get this, it reflects left ventricular end diastolic pressure. That's a big word for the end of diastole, the pressure in the artery. So the higher the wedge pressure, that means that the left ventricle is either suffering, or the patient's fluid overloaded, or the aortic valve is bad. So Mr. Robbins will apply this with you in cardiac surgery and arrhythmias, but I am just introducing the concepts. Here's a typical monitor in an ICU. Why would we need to monitor an EKG? Well, maybe the patient has an arrhythmia. Maybe they're having PVCs or ST depression. They're suffering from myocardial ischemia. they've had an MI, or they recently had a stent put in. Maybe they have a cardiac valve issue and they're waiting for a valve procedure. Cardiac output's usually on the screen, and it's measured in liters per minute. We're looking for 4 to 8. Pulmonary artery wedge pressure is not routinely seen on the screen, but you have to push the syringe to get the balloon to inflate to get the wedge pressure, and you can see on this monitor there's an average pressure right there of 16. I'm not going to be testing you on specifics of wedge pressures, but I want you to know when your wedge pressure is high, it usually means your fluid volume overloaded or your left ventricle is failing. That means the patient needs to be unloaded, and usually they're unloaded with diuretics, or we reduce the afterload with drips. Constant blood pressure monitoring, or the MAP, we can get these via something called the arterial line. That's another special catheter put in the wrist or in the groin, directly into the artery to give us blood pressure beat by beat. Some patients in the ICU have a direct end-tidal CO2 monitor hooked in right into their ET tube, and it reflects the ventilator's end-tidal carbon dioxide. So sometimes we don't even need to get a blood gas. It gives us our carbon dioxide. Continuous monitoring of SAT and respiratory rates also important. And so make sure to set all your alarms when you're an ICU nurse. If you don't set your alarms on these monitors and you're down the hall helping your friend on a code brown, you would not know if your patient pulled out their A line, which is something that happened to me and a friend working at a local hospital, just the two of us taking care of 4 critical patients, and her patient pulled out her A line. We had no clue. The alarms did not go off as they were never set. We found the patient in a pool of blood only when he suffered from extreme tachycardia as he compensated. So these specialized lines, the triple lumen, the pulmonary artery catheter, otherwise known as the Swan-Ganz or a cordis in the neck, these lines are very beneficial that help the nurse and the physician infuse the medications needed for the patient. Most of these medications might be a drip. I know in 232 you just went over a heparin drip. A very common heparin drip equation and a calculation is the patient is on a heparin drip of 25,000 units and 250 mils. The doctor wants 1,300 units of heparin per hour. What should we set the pump at? Examples like that could be on the test. I've uploaded the 232 practice problems for heparin because they may show right back up again. Dopamine or Levophed. There's a critical care math section on Canvas. Review how to do a dopamine drip. We can go over it also on Zoom. Typical calculation for a dopamine drip is the mix is usually 400 milligrams and 250, and most physicians will start a drip at 2 to 5 mics per kilo per minute. So you definitely need your weight. These are weight-based medicines. You look on your Kaplan questions for math, there's a weight-based question, and you'll see that when you're practicing your Kaplan. Cardizem or lidocaine, those are specifically for arrhythmias. If somebody goes into a rapid AFib, they may be put on a cardizem drip, 10 milligrams an hour, that's typical, or a lidocaine drip for PVCs or VTAC. So look at the practice drip math equations on Canvas. You know, there's definitely going to be one on the test, so you might as well start practicing now. There's usually a 3 to 4 step process to get these done. We could talk more about it on Zoom, and practice makes perfect. So take a look at this. All drips are run through a central line. Some of them have high vesicant property. Blood pressure is monitored continuously with A-lines when people are on these vasoactive drips. The blood pressure could drop on a dime. The heart rate could be affected. These are vasoactive drips that affect heart rate and blood pressure, second to second, beat to beat. So on to the next slide. So this is all about A-lines. Take a look at this little schematic. An arterial line is a catheter that's inserted into usually the wrist. So it's hooked also with a tube that's flushed with heparin or saline. Usually it's a pressurized bag. It has to be, otherwise the blood will back up. And it's run through a transducer which reflects the rhythm and the waveform on a screen in the ICU. The indications for a arterial blood pressure monitoring device would be somebody's on a drip and you need to titrate those drips. Perhaps they have an unstable blood pressure or they need frequent ABGs or labs. Remember, the arterial line is in the artery. The other catheters I talked about, those are all in large veins. Here's your sites and there's your complications. Of course, with any catheter in an artery, you want to check for distal ischemia. You want to look at the color. You want to squeeze the nail beds. You want to make sure the hand's pink, because what could happen? Yep, a blood clot. You get a blood clot on the tip of that catheter, you'll have ischemia distal, which would be like a discolored hand, pallor looking, numbness, tingling, that kind of thing. Sometimes we get a hematoma or blood loss, like the patient I told you about that pulled out his A-line while my friend and I were at a Code Brown in the ICU down the hall. So be alert to those. Most of these are taped down. You've got to be careful. If the patient wiggles around too much, it can become dislodged. So here we go again, nursing considerations. That's what nursing school is all about. Assessment and considerations and evaluation. And what should a nurse be concerned about? Monitoring a central line. Well, we're going to say it again. Infection, infection, infection. Here's 3 examples of central lines to the right corner. All of them are flushed, clamped, capped, have a nice tegaderm, and they have a stat lock on some of them. The nurse is assessing for signs of infection. The other thing is accidental removal, a confused patient. There's nothing like your confused patient pulling out their Hickman catheter, and then you have to call the doctor. How about a clot in the line? Well, if these aren't flushed properly and you get a clot, you have to follow the agency's protocol for how to address that. Managing the setup and flushing the ports, that's done with the flush bag, the transducer. We've got to be careful with A-lines about dislodgement, about a clot, about bleeding, about circulation, okay? We're always going to be monitoring the blood pressure or some ABGs. That's for sure with an A-line. They're usually kept in short term, 2 to 3 days max, on occasion 5. Well, let's talk about vascular closure devices. I know you just got out of 232 and you just had your cardiac lecture, so I'm pretty sure they went over an angiogram, post-cath care. Well, usually the patient comes out and goes to a specialty unit. It's a monitored bed, and so they're instructed to keep their legs straight, keep the insertion site straight, don't bend, don't move. Sometimes they have to lie flat for anywhere from 4 to 8 hours. The vital signs have to be monitored with any patient post-cath. But what about this vascular closure device? Well, there can be some serious complications. I loaded up a great article you can look at. It's highlighted and got great stars all over it for the top 2 complications with a vascular device. Now, more radial sites are used than ever before. The last 3 patients to come through the office where I work as a cardiac NP all had radial access sites. So that is the new wave of cardiac cath. They're all going through the radial artery, but we're still using, on occasion, the femoral sites. So review that journal article posted, Managing Risks of Femoral VCDs. Ask me questions in Zoom. We'll talk about the top 2 complications, and maybe I'll tell you a story about the guy who walked in dragging his leg someday. Anyway, the most important thing to note about these vascular closure devices, you can see the picture in the right upper hand corner, is that they usually will absorb into the vessel over time. You can see the collagen plug and the bioabsorbable anchor. That does stay in the patient for life, and they usually carry a small card in their wallet. So some types of these devices are like the Star Close or the Per Close or the Angio Seal. Okay, so go over your discharge instructions on Iggy. Some of you in the old edition is 644, and some of you in the new edition, I have you at 657. Okay. This is just a quick visual of the cath lab. There's the physician, the nurse, and the tech. You can see the device in the lower right-hand corner. That is the physician working with the device after doing an angio, and what the patient is going to get is a VCD to close off the access site. So you can see in the upper right-hand corner, the patient is actively getting an angiogram. They're inserting the dye and they're taking images. They're obviously looking for occlusions. You just got this lecture in 232, so I'm not going to go over anything else. But what should be monitored for when they go to the floor? What's the most important thing to monitor for? Okay, one starts with a B and the other one starts with an H. Let's see if you could guess. So, what kind of activities are we going to do in Zoom? Well, first of all, we're going to talk about any clarifications about the pulmonary artery catheter, intubation, the VCD, and the A-line. Bring any questions you have. I want you to practice those math questions because we're going to have some breakout groups, and we're going to do a dopamine drip, a heparin drip, and we're going to see if you guys are all comfortable with doing your math calculations. Remember, practice makes perfect. Now, don't forget to download the mini breakout. We're going to go over that document, numbers 1 through 5. We're going to talk about a K writer. We're going to do a dopamine drip. We're going to do your own cardiac output, things like that. I can't quite remember everything that's on that form, but download that form, please. What else? The 2 med-surg cases from Skills Day that we're going to discuss. We can talk a little bit about those, but we'll talk about them further on Skills Day. Get you thinking like a nurse. I'm also going to upload a special case of a patient that is an ICU patient. We can talk about that, some concepts, and some themes of care. Do your pre-lecture delegation questions. We'll go into breakout rooms again. We'll be taking lots of breaks. Something new, you're going to be going into the discussion room. By now, all of you realize the discussion room is open for you to participate in a little activity. So go to Pages in Canvas, click on Pandemic Link, and then head into the discussion boards if you want the 3 points for that discussion for this week. So remember, the library is open. You can get together with your peers. You could practice your math, complete your reading, look at the journal article on complications of VCDs. I don't think you'll be hanging out in the library like those four students up in the upper left-hand corner that close. We're missing masks from that picture. Will things ever go back to normal? I do not know. But for now, this is what we're dealing with. I'll see you guys in the Zoom room for lecture at 1 o'clock. I'll put you into breakout rooms several times, and we will take a break every hour, so I'll put somebody in charge of that. And I'll also ask somebody to be in charge of the chat room for me. Okay? Feel free to email me any questions, and I'll see you in the Zoom rooms.